All right, let's dive right in. Today, we are tackling a massive topic for pediatric anesthesia, and you can bet it's a favorite for fellowship exams: how to assess and manage a child who shows up with acute stridor. Nailing this is absolutely critical, not just for the exam, but for your patient's life. So here's our game plan. We'll kick things off with the absolute fundamentals of stridor. Then we'll get into the practical side of assessment and break down the most important causes. And we'll wrap up with the anesthetist's ultimate role, securing that very, very compromised airway. First things first, we've got to understand what stridor actually is, and more importantly, why kids are just so uniquely vulnerable to it. Okay, this is mission critical to understand. Stridor is not the disease itself. Think of it like an alarm bell. It's that harsh, noisy sound telling you that air is struggling to get through a partially blocked pipe. Your job is to figure out where the blockage is, what's causing it, and how bad it is, fast. This really lays out the perfect storm of pediatric physiology. A child's airway is already tiny. And thanks to Poiseuille's law, where resistance is tied to the radius to the fourth power, even a single millimeter of swelling just sends the work of breathing through the roof. Throw in a floppy chest wall, weak muscles, and a crazy high oxygen demand with almost no reserves, and you can see just how quickly these little ones can crash. All right, let's talk assessment. And the absolute #1 rule here is observation. You have to disturb a distressed, stridulous child as little as humanly possible. Making them cry can actually cause a complete obstruction. So keep them with their parents, let them stay in whatever position feels comfortable, and just watch. And this table right here, this is your visual guide. This shows you exactly what you're looking for. You've got the early signs like nasal flaring and recessions, all the way to that classic tripod position of a child who is desperate to get air in. But you have to be alert for those really ominous signs of impending arrest. A slowing breathing rate and a silent chest doesn't mean they're getting better. It means they're exhausted. And bradycardia, that is a pre-arrest sign. Don't miss it. This is a classic exam question. You can actually use the timing of the sound to help you pinpoint the problem. If you hear it on inspiration, you're thinking high up, above the cords. That's your croup and epiglottitis territory. Hear it on expiration, the problem is likely lower down, inside the chest. And if it's biphasic, meaning you hear it coming and going, that points to a really fixed obstruction right at or just below the vocal cords. Okay, so with the fundamentals of assessment covered, let's talk about the diagnosis you are going to see more than any other when a child comes in with stridor. Yeah, look at that number. Over 80% of the time, it's going to be viral croup. Usually, it's the parainfluenza virus, and it loves to hit kids between about 6 months and 3 years old. It starts out looking like any other cold, but then it blossoms into that classic barking cough and inspiratory stridor, all because of swelling just below the glottis. Now, management is pretty stepwise. Steroids are the absolute mainstay. We've got randomized controlled trials that have shown oral dexamethasone at 0.6 mg per kilo is just as good as giving it IV or using nebulized budesonide, and it's way less upsetting for the child. For the more severe cases, nebulized epinephrine can give you some rapid, though temporary relief by shrinking that swollen mucosa. So how do we track how they're doing and guide our treatment? We use a croup score. It's a fantastic tool to objectively quantify just how severe the obstruction is. A score of around 4 to 6 might get them admitted to a high dependency unit, but a persistent score of 7 or higher, even after medical therapy, that is a flashing red light for tracheal intubation. Okay, we've covered the common cause. Now let's talk about the rare one, the diagnosis you absolutely cannot afford to miss. Ever since we started using the Hive vaccine for Haemophilus influenzae type B, epiglottitis has become really uncommon. And weirdly, that actually makes it more dangerous, because fewer of us have seen it. This table is pure exam gold. You have to know these distinctions. A kid with croup looks unwell, for sure, but a kid with epiglottitis looks toxic. The onset is what we call fulminant. It's incredibly rapid and severe, measured in hours, not days. They'll have a high fever, they're often drooling because it hurts too much to swallow, their voice is muffled, and, this is key, there is no barking cough. They are sitting bolt upright in that tripod position because it is the only way they can keep their airway open. All right, it's not always croup or epiglottitis. Your differential diagnosis has to include a few other important bad guys that can show up with acute stridor. So think of bacterial tracheitis as a kind of crossover villain. It often comes on the heels of a viral illness like croup, but suddenly the child gets way sicker with a high fever and these thick, pus-like secretions that can literally plug up their airway.
On laryngoscopy, the epiglottis will look fine, but you might see that gunk coming up from below the cords.
Next up is a retropharyngeal abscess. This is literally a collection of pus in the space at the back of the throat, and it creates a direct physical blockage. The child's going to have a fever, they'll refuse to move their neck, and they might be drooling. The huge anesthetic risk here is rupturing that abscess during laryngoscopy and aspirating all that pus into the lungs. It's a disaster.
And you always have to ask yourself, could it be an inhaled foreign body? Sometimes the history is obvious, a sudden choking episode. But not always. Sometimes it shows up as a persistent wheeze or a cough, and it can even get misdiagnosed as asthma that just isn't responding to treatment. And that brings us to the final and most critical part of this whole discussion. What do you do when medical management just isn't cutting it, or when you're faced with a true anatomical emergency like epiglottitis? This is where the anesthesist truly takes center stage.
The approach here has to be calm, controlled, and just meticulous. This is a team sport. You're doing this with your ENT surgeon colleagues right there with you. You keep the child calm, often inducing them while they're sitting up. The absolute golden rule, and I can't stress this enough, is to maintain spontaneous ventilation the entire time. Applying a bit of CPAP can help splint that floppy, obstructed airway open, and don't you even think about putting an IV in until that child is deeply asleep. Finally, be ready to use an endotracheal tube that's smaller than what you'd normally pick for their age.
So if there is one thing, just one thing you take away from all this, let it be this. Stridor is never, ever normal. It is always a sign of a problem, and it can signal a life-threatening airway obstruction. You have to give it your full attention, a systematic assessment, and have a crystal-clear management plan. Always respect the stridor. This whole masterclass was based on the key findings from the fantastic 2007 review article, Acute Stridor in Children, from BJA Education. Mastering these concepts is an absolutely crucial step towards safely managing some of the biggest challenges in our entire field.